Hi, Samin. Good to see you again.
Yes, good morning to our conference, and thank you for giving us the opportunity. And myself, Dr. Keeney, my left side, and all our Cath Lab staff here to welcome you from Mount Sinai Cath Lab and demonstrate two complex cases, one coronary and one structural. Can you see us? Can you hear us well?
Laser.
Yes, Samin, this is
Okay.
Botelho, Roberto Botelho,
Good.
Fausto Ferris from Dante Pazanese is here with me. Hi, Kini.
Yeah.
Good to see you
Yeah.
again. And together with us, we have a wonderful panel to discuss with you, an international and national panelist. We have Fernanda Mangione from São Paulo, Guilherme Atizani from Case Western, Henrique Ribeiro from São Paulo, Zé Mariani Jr. from São Paulo, and Pedro Neto from Henry Ford University
In
Hospital,
the circle,
and
the balloon, then
Pedro
advance.
Sarmento
Seven front.
from Rio Grande do Sul, the south of the
Balloon the
them
circ.
in
Balloon the
both
circ.
coronary
Circle.
structural
One
heart
second.
disease.
To advance this.
Together with me, my boss, Fausto Ferris from Dante Pazanese.
Beautiful.
Good to see you. It's great to have Mount Sinai at our meeting here in Belo Horizonte, the Brazilian meeting of interventional cardiology. Welcome.
Fantastic. Fantastic. And I saw the very rich agenda of 3 days of the conference, and today is the third day. And as I said, that really thankful
Give me the field.
to be the part of it. So now let me show you this case quickly. Show the slide, please. This is our SBHCI Congress disclosures show here. This is the case number 1. 85-year-old patient with a known CAD, multiple PCIs before, and presented recently with class 3 angina and ischemia. Cath done about 10 days ago, severe calcific left main angulated disease with normal EF. Patient has a creatinine of about 2.2, EGFR is between 23 to 28. So his CKD stage 4. Other risk factors are there on a good medical therapy as shown below. So we'll show the angiogram quickly. You want to show the angiogram now? So this is the case. Go back to angio.
So EDP was normal and we have a normal LV function. I know his EGFR is low. We are hydrating a patient a lot. Moderate about a 30-50% lesion in the proximal RCA. Mid RCA has a patent stent. The rest of the arteries are good. And this is where we are with the left side.
This is the trouble.
Yeah. So we have significant left main disease. Angulated takeoff of the LAD. There is stent in the mid LAD which is patent, stent in the distal circ to LPL which is patent, but definitely it's a left main, short left main involving both ostial LAD and ostial circumflex on angiography, as well as you can see that before we inject dye, there is a tramp track calcium there, so heavily calcified left main.
And this is in the other view. Look at the very significant disease. The stents actually did good, was 6-7 years ago, although first stent was in 2006. So patient has done well with the stent and now have the new lesions as shown here. So what we did, we crossed the lesion with the LAD. We thought, let's see what's going on with the LAD lesion. We advanced the wire into the LAD and try to advance.
Go minus.
Sorry, here.
Okay, so if you see here, we have a VL3 or Voda right side. So the despite it was Voda right short.
The VL.
Good, VL, yeah.
What do you need?
No, VL left side. I want to go back.
Okay.
So we've when we are trying to wire with the fielder wire, which is a polymer jacketed wire, it was essentially going into the circumflex. Since if you see a circumflex, so then we changed into a run-through wire since we wanted a curve, like a C curve to get into the LAD. So with the run-through wire, we've been able to wire the LAD. So this is what you're seeing right now. Then we had a fine cross. We would not get the fine cross across the left main to LAD because of the calcium and the angle. Then we change it to actually Corsair, and this where we are. Even with the Corsair, I cannot get into the LAD.
Try to show it now. So we'll go active, we'll show it. I mean, it's like so difficult sometimes until you go inside the vessel. Look at this. Corsair with a very pointed tip. There is a run through in the LED, good purchase of the run through wire, and it does not go because there's so much calcium. So then question comes, is a uncrossable lesion. The two trick we thought, well, maybe we just put a wire into the circ and anchor balloon and then try to get a Corsair there, because patient will need a very small rota bar. What balloon we have? Give us.
2/512. So
Yeah.
that's one. Other thing is that if we really cannot get it, there are two options, that we can leave the Corsair as far as it goes and then change to rota wire, thinking that we'll be able to get into the LED, or right now we have a 014 wire across that we can think of doing a laser first, followed by rotational atherectomy. So
And
these are the
IVL,
two.
and then IVL. This
Yeah.
one will require multiple device synergy because it's so calcific. And I always say that you have to have a fluoro shot before giving the dye. Look at the heavy calcium of proximally. So now we are doing here, which we call anchor technique. When you're trying to advance, the devices don't go. So try to use your anchor. So here we are putting a wire
was
into the
thinking-
circumflex
I was
and
thinking-
anchor the balloon and try to then navigate the Corsair, because then we have to change it to the rota wire. If not, yeah, good. If not, then we have to use the laser. Laser is getting warmed up, takes about 5-10 minutes. I'm going up now.
Okay.
Okay, so this is the anchor balloon. And other question is, should we use to a floppy wire into the LED angle, and maybe then it will navigate. So
No,
this is a very
it's not.
unusual situation. We didn't expect this one.
Okay, I think we are able to get through now.
Yeah, do you see
Okay,
this?
yeah.
This is the classical example when you have trouble. Good. We are deflating and we are taking our other devices out. Both
Okay, give me
wire
the
and this. Yeah.
Here,
Rota
active
wire. We
mention.
have the
Rota
rota
wire.
ready? Yeah.
Where? Okay,
Yeah, let's take these two things out first. Fluoro?
very
Yeah.
good.
Okay. Roberto, you saw that that any difficulty, whether you have a problem in the side branch, many times that is what we do. Anchor it, and then you'll be able to advance. That
Give
gives
me
you
a lot of
additional
the
support.
flush
Guideliner alone would
syringes.
not have been
Flush
helpful
syringes,
or Godzilla in that situation,
Take this
because
out.
you needed to have a little more pressure, because guide is already at the ostium. Yeah, just 1 second. Keep holding this wire clean. Yeah, ready? Okay, so now we are pulling it very stiff.
Ay.
Wire. It's had a trouble. See, there's probably it's a bent, so you pull back. It's still the same. Yeah, wire cannot come. Would you believe that? So we cannot pull. Just rotate back in a different direction.
Except it may be that Corsair tip is gone,
Uh-huh. Yeah, okay. So we can do a dark wire, and we can go with get the dark again, and then do a different catheter, different micro catheter. But it
Unless
will
I'm
not go.
thinking it is stuck with the,
Means wire can pull back or no?
no, I'm worried it may break. It's probably stuck there
Yeah.
in that
So-
angle.
If the angle is stuck, I think we have to go back again.
No, I would not do that. I would just go with the laser.
Laser. Okay. So then,
get
yeah.
some
Input.
and,
Yeah, ask them what to do now. Right now, the wire is stuck. Our Corsair did cross, but it did not. And wire is jammed.
Okay,
Yeah.
now it's coming.
challenging calcified lesion. Would you help us with any comment on this case? Your
I
approach?
think just take this out
Yeah.
and let's do the laser, because it is
Ready?
stuck there at the angle. It won't come out.
Okay, let me see.
your
slowly.
Get the laser. Yeah.
Good.
Okay.
Okay. The wire is moving or no? Huh?
No, stuck.
So then do we get a 1O balloon? Try to see. Okay.
Laser will.
So this is the case. We are going to get a laser ready while you are somehow Roberto and other team. We cannot hear your panelists and moderators comment.
Yes, they are just turning the mic
Oh,
on. and,
okay. Now we got it.
understood. You changed from rotablator to laser.
Yeah,
And,
because point is we advanced the Corsair, finally went in with the anchor technique, but now the wire inside
Have the
does not come out.
fine cross ready. I may
The
need
wire
to
does
change.
not come out.
Yeah.
So wire is stuck at that angle. So question is what to do. So therefore we felt let's do the laser at this time. And if I can just complete my presentation while we are getting the laser ready, can you go back to slides quickly?
Are we
So
ready?
This is our case now. So initially supposed to be IVUS guided left main, rotational atherectomy, IVL, dedicated to stent technique, but more important now, we are adding laser. So appropriateness, as you know, the recent guidelines, you have to have
60,
heart team
60.
discussion, patient STS
60.
risk, syntax score and frailty. This case had a discussion, declined by surgeons, came from outside, syntax score is 26 and STS score 4.1 because of CKD and advanced age. An appropriate grade we always want to make. This is rarely appropriate, but there is no other option for this patient because surgeons have declined and therefore it becomes, in my opinion, appropriate after heart team discussion. With that note, let's go back live on our laser case, which is fine. Yeah. Okay, we go back live. Yeah.
Not yet.
Ready? Okay. So let's.
Hey, Samin, how
Yeah.
are you? This is Paterville from Henry Ford.
Yes.
Uh,
Yes.
Quick question.
Yeah.
So is your rotablator is which wire is the one that is trapped?
No, we didn't put it. This is right now the run through wire there. This is the run through wire.
Oh,
And
it's a
what
run
happened
through
is,
wire, okay.
yeah. So what happened is we had a Corsair, but then run through wire is so stuck at that angle, does not come out. So we've just brought the Corsair out and wire is still there. And now we are ready with the laser with the 60-60 fluence and energy.
Should
Yeah.
we anchor the guide because it's coming out? I don't think we're delivering the
Okay.
energy.
Yeah. No, but should
I
we
don't
have
know.
then
Let's see.
same is you can get a guideline or more here at this level. 6 French will be okay.
And, this
And-
is the
yeah.
static learning from Mount Sinai Cath Lab. A new tip and trick.
Yep.
Use laser. Then,
Because idea was just to change it to rota wire and use a 1.25 bar. That was the plan. But
Would
I
you
don't
try
know.
set
Yeah.
the wire into a circ and maybe balloon it into a circ, the left main, to see if you can, modify the plaque a little bit and help
Release.
you? Or
yeah, so we actually anchored earlier, and now that we were just talking about. That's what Dr. Kini was saying. So why don't we open left main to the circ with a cutting balloon or IVL? Well, may not be IVL yet because things may not cross. And maybe just open with the balloon now. Go to what?
80.
One more. No, we have to flush.
Yeah, you're not doing it. That's what I'm
But
saying. Do
one
we
second.
get with the anchor it with the circ? Because I think it's not
Okay.
staying there. Yeah. Okay. Don't give tire. I remember last time I dissected once. So careful.
Yeah, slow. Yeah.
Hmm.
Good.
Okay, I'm engaging.
Even the laser is having a tough time. Yeah, that's okay. I think it will do it now. Get a 1O balloon. Yeah, go. Yeah. So otherwise,
Okay,
we'll
now
be-
a wire is a little mobile.
Yeah.
Hold on. Let me do one more
Yeah.
laser.
Yeah. And we are doing a saline flush. We do a dye flush only in a cases with the ISRs. I think it had made the curve. Good.
Yeah.
Okay. Let's take it out.
Okay.
We will.
You want me to try again?
Which
Or
one?
maybe fine cross, no?
No, but let's see balloon. Just see the balloon goes, and then we go back with the fine cross, and we can still go back more with the laser. But laser go with the 80-80. So uncrossable lesion is the most important indication. Now, right now we have 1O balloon, and see. Otherwise, we'll put a wire into the circumflex, use a 3O flex tome, Wolverine, and
No,
open it up.
I think now, give me the fine cross.
Okay. Anyway, we're getting a 1O balloon right now, 1O sapphire. Try to see if it goes through, and otherwise we'll try the fine cross again. It went in. Good. So you want to just do
Never
nothing?
seen-
Yeah, do it a little bit. Ostium.
No.
Do the ostium
Okay,
or
go,
not?
go. Do a little bit. Fine
just-
cross ready, and then we'll change back to rota wire. At this time, we do still 1-5 or 1-5?
No, 1 to 5. There is no question. This case is 1 to 5 because then we combine with IVL. I think
Okay,
ruptured
good.
already.
Down.
Balloon ruptured. At 8 atmosphere, it is ruptured.
Okay, give me the fine cross.
This is another very important tip to choose the 125 burr
Yeah.
because
Yes.
this is a large vessel.
No, but here you're right. The question is very important.
Rota wire.
Yeah. The very important point here is that we have a difficulty in crossing. Any time you have a trouble advancing your micro catheters, you go with a 1.25. IVUS did not go 1.25. So that's the reason now. In the past, we used to worry about what to do, but here it's not a problem because now we combine those cases rather than doing upsizing burr. Good. Very good.
Okay, so now,
But
hold on.
just if you could explain
It's
us
not coming
how did you change the wire? What was your
Still
sequence?
stuck. No, so this one was basically first we cross with the run through wire and even the wire is stuck right now. Huh?
There, right there.
So advance the wire as much as possible.
No, I mean fine cross.
Fine cross and then try to pull back the wire. Wire is not coming out.
Can I ask you a quick question, just
Yeah.
for the audience?
Yes.
When would you, why will you pick rotational versus orbital?
Yeah.
And
So
you,
I think majority of time, except maybe aorto-ostial or angulated lesion, we go with a more rota, but otherwise between two of them are interchangeably. So even now, the run through wire actually giving us a lot of trouble and
That's the angle, you see that?
yeah. So, but yeah, so I think the overall in our lab, actually, we are more rota 70-30. So 70 rotational atherectomy, 30 orbital. But this kind of lesion, I definitely will go with the rota because of that angle compared to orbital. Because orbital does cause a little more wire bias and so. So, okay, wire moved now. Good. See if you go back. Yeah. But otherwise, I think both are good technique for debulking, modifying actually plaque, and particularly the calcific nodule, because that is one IVL actually works quite a bit, but many times it's tough to advance. So here, wire advancement is so difficult. You want
And
to
you
go with the
plan to
course here again?
larger bursts?
Yeah. So yeah, so key is that now I think step burr used to be like 15% before the IVL use.
Give me
in our
fine
lab.
cross and I'll try to do.
Yeah, this is stuck.
Yeah.
Yeah.
That
Yeah,
was
the
a problem.
Point is because of angulation, the wire and both stuck.
No,
Get
give
a
me
new fine cross and new go with the
I'll
fielder
go
wire.
rota wire.
Fielder wire.
No,
Do you have,
rota,
do you have
no.
a 6 or 7 French? I'm curious for
This is the
support.
7
Seven
French.
French,
So
yeah.
because our plan was to do a mini crush, then need a 7 French. Although DK crush you can do with a
Yeah,
6
yeah.
French.
Open. Flush
Yeah.
it.
So that is the basically 7 French guide we have. There was a lot of dampening even with a diagnostic catheter. So we actually make a side hole in this catheter. Although patient has a little high creatinine, but we had to make a one side hole. Many times when you are dampening right or left, it's better to make a side hole.
Will.
Otherwise you have decreased flow. Yeah.
CCU bed.
Go. Okay, now we are again, you're right, we are changing the strategy. Because angulation is calcium, our device and the wire is stuck. We took everything out. Now we are going with the fine cross and the fielder wire. Get a new run through also.
Meaning another strategy, and
Yeah.
correct me if I'm wrong, but sometimes what the CEOs people do, you send the wire into the side branch and you shockwave it and you modify the side branch with shockwave being now the side branch, the left main. Would you consider that shockwave?
Well, I mean, I think that is one will be the second option. Take a run through again. Yeah. So that will be the option.
Go
that
to the
Egypt-
other view.
No, this was the view you did. Yeah.
That
So-
view.
Huh?
Helio 1439.
Yeah, we'll do it. Yeah. Are you done? Yeah. So question is always that we try to open up. Maybe there's all resistance is occurring because of that calcium. And my only question comes, whether the shock wave will go through this even to the circ, because left main itself is so calcified.
It may go.
Yeah. Huh?
It may go.
Yeah. So this is the guide now. Guide is okay. No, we have to get better position of the guide. So
Okay,
guide
now.
becomes soft, which always happens.
Okay.
You want to go with the run through again?
Let me see if I can get into the circ at least.
Yeah.
That is not engaged. Okay, now.
No, pull. Yeah, good.
No. Okay.
Yeah, good. Now this is the guide position. You put a wire into the circ at least. If we need to be, we go with the, we have a 3O IVL ready.
Somebody has to hold the guide, I think. It's not.
Want to go with the run through again? Yeah, get ready 3O.
No, we're not good with the guide. Not good with the guide. Okay, some there.
Just hold it, hold it.
Hold it.
Holding the guide there.
Okay, good in the leave in the circ.
Yeah. Yeah. Now bring
Let's
the guide.
do the no. Let's do the IVL into the circ.
Okay. Get the
So
dark
what we'll do is we will do the IVL into the circ. Yeah, get the duck quickly.
That sounds like a good idea.
Yeah. So, yep. Good. You prepare that. So 3O.
And then I will need a run through again. Okay, so I can maybe get into the
We have the run through
already.
ready. Yeah.
Which
New-
shock wave balloon size are you going
Yeah,
to
right
use?
now we are going with the 3O. Remember, we are not open the vessel. We want to do 1-to-1. We know that. But in this particular case, I think the issue will be crossing the lesion.
Should we IVUS?
No IVUS right now. You want to do IVUS now? No, I think we do IVL first. Then you can do IVUS. If IVL does not go, then may
Then no, then it's okay. We can do rota in the circ.
yeah.
Okay.
So why don't you IVUS first to have the understanding of the real size of the vessel? Because for the IVL to work appropriately, you're going to have full contact with the balloon with the vessel wall.
Yeah.
So
No, in this particular case, I fully agree. Only question difference in this particular case is, I think we'll have a trouble in advancing. And that you're right. IVL to work effectively, it need to be 1-to-1 vessel size, not the MLD. But I'm just trying to see that we can get some lumen, and then of course we are ready with the IVUS catheter. That was our initial plan was to do the IVUS.
And Dr. Sharma, how many
Yeah, good.
pulses do you intend now? All the 80s?
Yeah, so I mean, this is allow up to 8 pulses or 10 times 8. Now, anyway, this is 3O.
4.
Ready?
Yeah.
Okay, just show the floor. Okay, we are going to the 4 atmosphere now. Good.
Okay. Now you know what I want to do?
Delivery?
No, I want to pull back. 1 second.
No, start here. That's okay.
There's nothing there.
Yeah, good. We are doing it now.
There's nothing there.
4 atmosphere, and then we pull back.
Done.
So what you do is then 4, then becomes 6, and then you deflate. So that's the sequence. And of course,
Go up
good.
here.
Okay. You're going to deliver 4. Go. Okay. This is now. Now we should.
Fine cross ready?
Show the hemodynamics one side.
No, it's okay. You don't need it. Okay,
Yeah.
good.
6 and then come down.
I want to do one more here. Okay.
Yeah.
So we truly taking care of the left main with IVL here.
Okay.
Show the hemodynamics there. Yeah, good.
Yeah, you can go to 6 up to maximum 6 balloon pressure, not more. Yeah, go. So key is 6 pulse. These are it's a 10 second. You can go up to 8 times. Good. And before deflating, you go 2 atmosphere more. If it was 4, go to 6. It was 6, go to 8. Don't go beyond 6 atmosphere for the inflation. Good. Okay.
Seems to be fully expanded despite of the calcium.
Okay, ready?
Yeah. Okay. We are taking a
What
picture
is
now.
the metric you used to, because you didn't use all of the shocks available, you could have shocked more, right? Why did
Yeah.
you take the balloon out? You think you're good?
Yeah,
No, no, because we are-
I think
it
we
looks
want
we are-
to use this remaining shock into the LED.
No, plus you saw it was fully expanded.
Yes.
Yeah, then you don't need to keep
Yes,
going.
is that once it is fully expanded, because this is a too small balloon. I mean, it's almost a 4 millimeter, 3.54. But we use purposefully because what has happened when we started this case, everything is tough to engage, to advance device and so. So we go back again.
Fine cross.
Fine cross ready here with the run through. And we are going back again. See, so far so good. You saw the picture? That's where we are now.
Let me make a better curve. Give the needle. Run through needle.
Okay.
So we are going to use a run through to get into the LAD on the fine cross and then see if we can exchange it to rotawire now.
Do you consider
this-
any support?
Yeah,
for
in
this
this particular
complex-
case, yeah. So in this case, because of the EDP was normal, patient is little hypertensive, ejection fraction is 55, 60%. We repeated again. So we felt that maybe we can do without. But you are right. If EF would have been less than 40% or so, then it's ideal case. And this is where the trial ongoing also, Protect 4, with a left main, with a complex disease. And we actually right now, they have enrolled about 160 cases. And Sinai, we have done 30 plus. So we are the lead enroller in the Protect 4 trial. But in this particular case, the hemodynamics, I think, is not necessary. One simple reason that EF is good and EDP is good. Although EDP never comes into equation, but definitely ejection fraction. So because of that, we thought that not needed. And also one of the issue remain once you use the say device, the impella or so, if you do a single axis, it's a little difficult to advance. Yeah. Good. Yeah. Good. Okay. Good.
Give me the run.
Yeah.
Oh,
We're ready with the run through wire. Yeah.
No, wait. Where's the?
We're ready with the rota wire now.
Okay, good. Take it out. Yeah.
Keep this wire.
I think we can do 1.5, no?
Okay. Do the 1.5 bar.
New. Give a new one.
To me, 1.25 is good right
No,
now.
I
You
don't-
have it open, huh?
I'll do nothing. We did balloon, we did laser.
Are you planning to shockwave now from left main to LAD or rota?
Yeah,
again?
but after rota. No, I think it will be, it will be a tough. You know that there, we did a laser which never crossed. Then we used a 1O balloon which ruptured. But at least what it did, it allowed our devices to go a little easier.
1 to 5? You want to do 1 to 5
Yeah, 1
only?
to 5, 1 to 5. So question is, as soon as we do this lumen of 1.25, then we are going to do the shock wave. We have those pulses still there. This is the case, then
You
become the
cannot do it
laser.
without imaging. You cannot.
Huh?
You have to image. We may have to make it
Yeah, but
3.5.
after, I know we'll do imaging as soon as we finish this 1.25 rota bar, and then we can do definitely the image to really understand that the angle and the calcium circumference in that ostial LAD.
So having done laser, we did shockwave in the left main. I was questioning that though we had 1 to 5 bar open, that should we go with 1.5 bar in the LED?
Yeah, so that was the question was, can you go 1.5? I say since we had a 1.25 ready earlier, because of the angulation, we felt that let's just do 1.25 and then combine with a rota shock.
Pull.
So basically, okay, once we are there,
That's
so this is, yeah, Rota Pro is ready and 155 RPM outside. And we are, yeah, sorry, question you had?
So the side branch wire has to come out. So we took out the circumflex wire.
All the people have done that you put a
With a
guideline
guideline,
or micro catheter onto the side branch wire if you're worried about, but I think this is a particular,
You
okay.
cannot put
We never done
micro
it,
catheter.
but there are in the
guideline.
report that how can you protect the side branch, you can use with the additional devices. So here, we are
So-
ready to do Rota here.
Can you show the, yeah,
That's
so
right.
essentially the 3 steps, you move your knob backward, forward, the tension between the Teflon sheath and the bar is gone. Then we are at the Y connector moving backward, forward, any tension between the bar and the wire is gone. And the last, on the dyna, you just do a tap. So you see that the bar did not move. So we are ready to burr. Blood pressure is good, EKG is good. You can show the hemos, and I'm just going to start burring. Slow pecking motion, backward forward, slow pecking motion.
See, it's still a drop in RPM. So much drop in RPM from 150 to 138, means significant drop. So I think 1.25, but choice was appropriate. Good. Okay. Now we are going to take out. And we have to recross. And question is, do we do a IVL first or you want to do a imaging first?
I would IVUS just to go 1-to-1, otherwise.
Okay.
Okay. Get me a run through to get into the LED, and then I need a fielder for the circ.
Yeah. Okay. Let's put a.
So let's IVUS from left main to LED.
Yes.
See what's the IVL size.
Right here. Yeah. So it is a big vessel. Left main, of course, 3.5 plus. Our imaging team is ready here with Kiski, and we are going to just see here. We are trying to avoid multiple angiograms because of creatinine high. So as you saw it, we are very timid or miser, you can say, in showing it. But IVUS intravascular ultrasound will show, and that is the advantage of the IVUS versus OCT. OCT is good in this situation, but because of the additional dye use, I know some people do with the saline flush, and so we felt that this is appropriate case for the IVUS, not for the OCT because of creatinine issue. Good.
And so far, we got wave balloon, laser, and Horabelo.
That's it. And IVL will be ready. So there is a name, we call rota shock or laser shock and rotatripsy. So this one will become the rotablation, laser and shock. Maybe the rolo shock or rolotripsy. All three. We actually have a 2 weeks ago our live case. In one case also we have similar situation. We end up in using all three devices. And multiple times IVUS did not even cross. Okay, so IVUS is going in. Ready?
Okay, we can show the IVUS on the instead of the fluoro full screen.
Wait for the image.
Yep. And fluoro on the side also, no? Yeah, good. IVUS went in.
Yeah.
Without any problem.
Good. Start.
Yeah, start fullback. Looks like it's an old stent, mid LED.
Hold it.
Old stent is expanded, and a lot of calcium outside of stent. Yeah, lumen is open, come to proximal. Yeah, I can see the 2 quadrant calcium. Yeah, 3 quadrant calcium.
So vessel size about 3.5.
Yeah, looks like 3.5. Yeah, so tight. Ostium, it's a left main.
Good.
Yeah,
Done.
aorta.
Came back.
Super short left main. So I checked the LED size.
Say 3.5.
Like at the start of the pullback, the
3.5.
EL to EL
Let's
is
get a
looks like
3.5
3.5. So maybe we can do 3.5 LED.
3.5, or we use the same right
Yeah,
now.
3.
So
Okay,
this
so
is-
what is the minimum vessel size was? What was the
the
vessel
start
in
of the
ostial
pullback
LED?
is like almost 3.5. The LED EL to EL is 3.5.
Okay.
Yeah.
Rota wire we can throw away.
And
We don't need the
approximately
rota.
LED has a like 270
Okay.
to
So you
360
want to put a wire
calcium.
in the circ now or later?
Later, let's do this.
All right.
Uh,
So right now, since we have, and maybe we don't have enough pulses, so in about 10%, 12% cases, even in the trial, they needed to go 2 devices because the pulses are capacity is 8 pulses of 10 seconds each. But here we are going with the trio.
Kiski, can you see some rotational atherectomy modified area? So
sure.
show.
So, yeah, it's at the ostial LEDs. So yeah,
You can
sure,
see.
but some little bit leaf ablation. Looks like it's ablated the 6 to 7 o'clock by 1.25 loaded. Yeah, but still 270 calcium.
Good.
Okay, good.
Okay. Go up. 4. Okay. This is the same shockwave device which we are going back and we are going to deliver, and you'll see it many times it opened up very nicely.
Now you can give all the rest.
Yeah. Go to 6 and negative. Good. We go again. One
And pull
second.
back.
No, just right now one more here.
Okay.
Go 4. Yeah. And then we'll pull back. Good. 6, negative. Okay. Yeah.
Okay,
Good.
good.
Ready?
Yes.
Good. 4. Now you can go to 6 actually. Go to 6. Yeah, good. Okay, we're delivering again. Now see this. The dent, once with continuous
Angle.
delivery, it will open up.
No.
But this may be just the band.
Yeah, but,
8, negative. Yeah. And we'll do one more. So that's the, we are heading to the, yeah, let's do again. Here, right here.
okay.
Go again.
I have the fielder ready.
Yeah. Okay. Do it again. It definitely opened up. Put a cine. We're not giving any dies. Yeah. Yeah, negative.
There's a little
Yeah.
little waste on the balloon or no?
Yeah.
No,
This-
I think that's the way the LEDs take angle of the LED.
do it
Yeah,
again.
go
Last
here.
one. Go. 6. This is the last one left.
But patient is tolerating it very well. No EKG changes. Blood pressure is okay despite us in the distal left main.
And we cannot see from here. Is there another wire in the circ?
No,
Not yet.
we
are going
haven't
to do it
wired
now.
the circ yet.
We
No.
are going to do it now.
So we did discuss that. There should be wire before or after.
Yeah.
We did not.
But a very important point. The IVL is a device where you can leave the wire in the side branch.
Yes.
Compared to any of the atherectomy catheters, you cannot. The laser is plus minus. I mean, there is no real data that whether you can leave the wire in the side branch. Yeah. Okay, so here they're telling let's go
No,
in
no,
the
no.
circ.
Let's finish this case
in the
more.
circ.
There's nothing much there.
Yeah. So
No?
now Roberto and other team, what happened is we will be ready for our structural case, knowing that this case still may take a little more time. Do we can get 5 minutes extra here, or we have to finish exactly at 10:50, and 10:15 means your 11:15 time. Huh. What do you think? Can we get extra 5? Because now we are going to modify.
Yeah, that's going to take less. It's not a lot there. You have 45 minutes for the tower?
Yeah.
We don't have that much.
Yeah, so we can definitely show that case tower in tower in 40 minutes rather than 45, because I'm sure people will be more interested effect of IVL and all this combination in this particular case, right? You agree, guys? Good,
Yes.
good, okay.
Okay, so now we are going to take the picture. So we wired the circumflex with fielder, we run through in the LED that is having done the
3.5.
shock wave there.
Yeah.
Now we are going to take a picture here.
Good. All right. Now we are talking. So now question is, do we go with the high pressure balloon only, or we want to go with the?
No, don't get too crazy. Let's do high pressure balloon and stent. Yeah.
Okay, good.
So get us a 3.5,
3.512.
both side. Yeah.
Balloon.
Fine balloon. What about Wolverine
Yeah.
or a cutting balloon?
Yeah. So question is, do you need cutting balloon now?
I think having done rotational atherectomy, laser, and we should not be now.
Yeah.
If you really did a good job with the shock wave, we should not be then going with Wolverine.
Yeah. So, and let's talk about the stent strategy now.
So we are going to do a mini crush. So we will have a 3.5, right? 16. Into the circ.
Okay.
And 3.5,
Now, circ is 12.
12. 3.5, 12 into the circ and 16 into the LED.
Yeah.
Sorry, LED to left main.
18. Yeah. 3.5, 18.
No, wait, 20. Promos.
Using Promus. Okay.
Why you have to use other one? Nothing like that, right?
So now what is the stent commonly used in there? In Brazil, it's a Synergy, Promus, Zions. What is number 1 stent there?
Go.
Panelists, any
Yeah.
preference for this case?
20, 22.
Or the science means.
Zions. Yeah. So this balloon ruptured despite all this. At 22 atmosphere, 3.5. emerge ruptured. So we have a 3O balloon separate for the circ. Let's do the circ with that. I think this is okay, but I think it has done its job. Yeah, good. Yeah. We are going to the circ now, 3.5 left main to LED and 3O here with those get ready, those.
Any tip from the image that make you comfortable that you successfully expand the stent?
Kiski,
Hmm?
he's asking the question
Yeah, so-
based
yeah.
on the IVUS that you have done.
Yeah,
Are
after
we
the loader-
comfortable that the stent will expand?
Yeah, after the loader a little bit ablated, like osteolated, and after we did the IVL, we don't have an image after the IVL, but it looks like not diffuse, like the severe calcium is like spotty. Like you can see also there's some not super calcified lesion, so I think it's expanded.
Done.
Okay, it's looking good. I think that's okay. Now people have done, actually we had done rare like 6 cases. We do about maybe 40 IVLs, 30 actually, between 30 and 40 now, around 30, 35 IVLs per month. We do overall atherectomy about 75 per month. We do 350 interventions. So 25% are atherectomy because of the cases referred to us. And we are ready for the stent now. 12 first.
12.
Yeah. So therefore, what we have
Can we
found
put the bifurcate on the side?
yeah.
Video?
So we felt that once you have done this combination, your stent expansions and acute results are always very good. So this is now 3.512 going into the circumflex.
I understand you're trying to save contrast, but is there a role to understand whether or not you did a good preparation of the lesion to do OCT in this LAD? Because it's hard to make this call with IVUS because you don't know if you fractured all the way the thickness of the calcium. So you might have impairment of the expansion of the stent, which is, of course, a big deal.
Now, Kiski, are you able to say it's a superficial deep calcium there on the IVUS there?
Of course, as the moderator said, it's IVUS, so we cannot see the depth of the calcium. Of course, OCT is better, but for this case, there's a lot of creatinine and osteal lesion, so hard to see the OCT. So yeah, definitely I will say how to predict the expansion.
So you ask a very important point that what are the imaging parameters that you are done before stenting. So that's a very, very important point. And I can tell you, no matter what has been published, they're all good guidelines where you should modify. Where is this? But when you should just, you think it's enough, maybe some data from the OCT as you mentioned, but in this case with a 2.2 creatinine, I would say that probably will avoid doing this in OCT in this particular case, but other cases will be appropriate to make that decision that have you decreased the thickness of the calcium? Have you shaved it? That less than that all calcium, which let's say it was 3 millimeter or 2 millimeter thickness, have been cut by 0.25 or 0.5. So that tells you that yes, that enough change has been done, and you will be okay to put a stent now, debulking. Now, if you have unexpanded stent, now there are data that you can use acute after for the unexpanded stent. You can use the IVL for unexpanded stent even after your stent deployment. In the past, that was a trouble, and you actually have a very little device. So I think let's take this stent out right now. Get a 3.5 because we did not do a good job there. 3.5, 15 high pressure again because balloon ruptured. Yeah. Get a new 3.5, 15. So you see that the balloon ruptured there, so that the stent is not going further. This is after IVL, this is after rota and balloon to inflation, and one of them actually balloon ruptured. So therefore, preparation is very important. And yes, OCT might give us a little better clue, but truly we still, basically what we as an interventionist want, kind of AI at this point to tell us that we do OCT or IVUS, and it tells you that, okay, enough plaque modification has taken place, go ahead and go put the stent. So we don't have any of those criteria now. For stent expansion, we have very good criteria on the OCT. It tells you the red dots where it is not expanded or there is a dissection. But has the adequate modification be done? I think we still lack some of the imaging. Maybe you can hear from the other panelists there.
Can I ask you a quick
I think
question?
it's
We
too
see on
long,
the
too
image
long. Can we go 15?
Yeah, it's 15.
Get a
Do you
15.
usually-
It's okay, 18 will go. Yeah.
No.
with
Yeah.
another,
Yeah.
you don't use the balloon to crush it? I'm curious. I'm looking at the app.
Ruptured again. It ruptured. I'm sure it's out ruptured. Get another one. Maybe 12. Get a 3.5.
Can you give
12 high pressure.
other one and see?
Yeah, I'm sorry, what was the question?
Track balloon. Track.
Yeah, other question will be that here you can do a DK crush. That we do a crush, kissing balloon, and then do a final. So, but
And
key is that there is still a spicule of calcium there.
And aren't you reconsidering now to use a cutting balloon instead of?
Yeah, let's do the cutting balloon then. Yeah. Give us a 3.5 Wolverine quickly. Yeah, so you're right. Let's do the Wolverine because our other balloons are rupturing. Yeah,
What is this?
Wolverine,
3.5?
3.5. Yeah,
Oh, we got it?
yeah, we have it.
Wow.
3.5 Wolverine is going, and clearly that your stent is a little further. Hopefully, it will be able to make through.
I would change it to 15. I'm telling you, it'll go. Stent.
It's not going. Yeah, good. Yeah. Okay, see fluoro. So this is now 3.5 Wolverine is going.
Then now you complete this cycle with the cutting
Yeah.
balloon.
Now we used everything.
Everything, what is available on the earth, all the devices, but that is okay. In these tough cases, that's the usual story. And now we are going to park the circ stent little distal.
Okay.
Yeah, good. Wolverine went. So Wolverine is, now you can go at least a little more than what used to be. With other flextome and so, you can go to 14 atmosphere, 16. Rated burst pressure is 14 right now.
Okay. Burst it.
Nope, it didn't burst yet.
No, burst it, I'm saying. So
No,
we know.
No. Yeah, so go a little further.
Okay.
Go further.
Down.
I know, done. Go further a little bit. Yeah, here.
Okay, yeah,
This is the one what trouble was giving us. Again, 14 atmosphere,
No, I would go higher.
16. Yeah, good. Very good. You want to go a little more or it's okay?
Cutting balloon further back.
I would go high pressure, 20.
Yeah, and we do up, yeah, here.
I would go 20 here.
Further back, yeah. Here we are going to go 20. Show that 20. Actually didn't rupture.
Okay.
Good.
Wait.
Good, okay. Now
No, there's something. Did you come down
Yeah,
or
one
you did not
below.
expand?
Yeah.
Go up again.
Get 1 millimeter back. Yeah, good.
Okay, go.
Yeah. No, we are going.
No.
Yeah, ready? Yeah, good. Done. Good.
Did we expand it?
Will be okay now. Good. So key is the same, that I think one step which we missed, that when we had a rupture balloon in the LAD, we should have gone with again either high pressure balloon or Wolverine. So that created our trouble. So same thing learning. So that whole modification of the plaque is very important. Despite we had done the IVL, we had done a small balloon, and then big balloon ruptured. So key is that we needed to modify it a little more, and now this stent should go. This is the 3.518.
Yeah. Pablo,
Yeah,
have a
science.
15 ready.
Good. And we have to come up to the ostium, so you need 18, yeah.
I know, but may not go.
Yep.
Don't open.
Good. The 7 French guide will take 2 stents. Yeah.
So the mini crush technique we are playing on the app, which is bifurcate app. It's playing on the top in the side. We are
Guide. And the guide first.
You always crush the other stent. You don't use a balloon. I
No,
usually
we'll
use
okay.
a balloon.
It'll go now.
yeah.
No,
Now
get
we
that.
are good.
Remember, circ was nicely open. You hold it there. Yeah,
Which is
circ was
circ?
nicely open.
Wait.
So bring back the circ.
Okay, good. Yeah.
Yeah, good.
Okay, good. Go up with the circ.
Yeah. Circ, I'm going.
So we're going up with the side branch, circumflex. You have 1 millimeter sticking in the left main. Good. Okay. Go up again.
Yep.
We need a 408
Back.
pot.
Yeah, 408 pot. Yeah,
Give us a 408.
yeah, good.
Okay, I think we're looking good.
But
I
fine,
don't
we
know,
don't have to
wait.
see. No, take the wire out. Now we are going to take that wire out of the circ, because once for the mini crush you have to go. Ready?
Okay.
We are going to the now.
Some die. So we'll make sure we're ostium.
Yeah, good.
Want to pull back a little bit?
Okay, pull 1 millimeter back. Okay,
Okay, good.
going
Go
up.
Good. Go up.
Yep. Same.
So this is a 3, 5, 18 in the left main. Okay, go up again.
And then this is the case which we have to do a pot and final kissing inflation. Whether you do a kissing inflation first, then pot, that's always matter of semantics. But we wanted to just show this, and then we'll be ready, because remainder part will complete offline. Yeah. Okay, you take these balloons out. So take one picture. Yeah. Okay, let's see, guys. It's been a long day here in terms of this case. We knew that it will be tough, but didn't expect even us that it will be that super tough. I mean, to have
Wait.
once the catheter goes and get stuck with the wire, I mean, that was amazing. 2 times it happened. And the laser was the savior, because nothing else was going in this particular case. And then, of course, combined with a small rota burr, wire has come back here, which is fine. Let's get the... Yeah.
You pulled back.
We need other wire, 35 wire. Take this one out yet. Yeah. Okay, so let's engage. Let's take a picture, and then we just have a 1 minute discussion, and then we'll go to our next case. We are ready there. Yeah.
For those of us who are familiar with your live course in New York, this is your standard. Very complex case, wonderful
Yeah, good,
techniques and tools.
Sine.
And for the
Ready?
first time, we saw all the techniques in the same case. And yesterday we asked this question: how complementary are Rota to wave balloon? And you
Come
very
back.
clearly
Good. Sine.
showed us.
Yes.
Any other questions from the audience or from the panel?
Look at that. Wow.
So-
We'll complete this one. Go to the slides now. You want to just show your things. So we just wanted to complete this so that make all the remaining educational points. Go back to slides, please. How did they get back? No, go back.
Go back to the slides. Yeah.
Okay, here. Nope. 1 second. Just leave it.
Uh-huh.
Just 1 minute. Wanted to show. No.
Yeah.
Why is
So
it moving?
who is moving? Leave
Yeah.
it there. Yeah.
Yeah.
So just wanted to also highlight all the apps that we have created that are going to help the interventional cardiologists. So they are available on cardiologyapps.com. Everything you can download either on the Apple or as well as on the Google Android phones. So our initial one came out way back in 2000 and about 8 years ago, Bifurcate. That was just an illustration of the various technique. Then we have one on OCT to understand, how to diagnose the various features on the OCT. Then engaging. The one that is the next case that we are going to show is access, coronary access after TAVR valve placement. That is TAVR cathode. Of course, we have transeptate if you are doing mitral procedures. Calcificate is the one to understand, various devices for calcific lesion, like what we have shown here. We have a lot of case example. Complicate is a web app. We have over 800 angiograms there, several case studies of the complications that happen in the cath lab and how to manage this complication. All these cases are from Mount Sinai, and the way we have dealt with these complications, so we have discussed every case with the angiogram right there. And 3D, Bifurcate 3D was a new release last year, which we showed you side by side. It's an animation which everybody probably understands better, the various technique, whether we are doing left main or the non-left main. STEMI app is a communication platform. It's about patient details. But more important, guide wire that we just released last year in November. There are over 130 coronary guide wire discussion, library of the wires and cases, to say which wire in which particular condition and description of every single wire, whether it is a CTO wire or a non-CTO wire, is a great understanding for all the interventional cardiologists.
Okay. So with that note, if any other question, we can just go to our, give us 1 minute and we'll be ready for our structural case, tower in tower.
Okay, thank you to our wonderful, and Kini is the digital interventional cardiologist that every year wonderful apps, and it's doing great. We wait for your cath lab change,
Okay.
and because of the sake of time. And
We'll
meanwhile,
be very
we
quick.
discuss with the audience.
Thank you.
Case and
Thank you. No,